And now it's my pleasure to bring to the program Dr. Richard Bebout, who is the Chief of Crisis Services at the DC Department of Behavioral Health. Richard, welcome to WIN TV.
Thank you, Denise. Thank you for having us.
No, it's our pleasure. We have enjoyed and learned a lot from the guests that have appeared before you, from the Department of Behavioral Health. So we're so glad to have you on because, you know, one of the big issues that I know that you're addressing that our city sees a lot is these mental health crises and what we do about them. So could you tell us a little bit about the crisis services and your work at DBH?
Yes, thank you for the opportunity to talk about that. We're doing a lot of interesting things. I've been with the department for just under 4 years at this point, and I was serving as Dr. Bazran's Senior Deputy Director. When 2 years ago, here in the district and nationally, there really began a seismic shift in how we were thinking about behavioral health crises and how do we move away from an automatic law enforcement response to a clinician-led health-first approach to people experiencing behavioral health crises. Some additional positions were funded, and with Dr. Bazran, we crafted a new role. I'm now serving in the role of Chief of Crisis Services. And the reason for that was really to make sure that the DBH operated crisis services were operating as a single continuum, if you will, and to strengthen our partnerships with other entities like MPD and Fire and EMS and Office of Unified Communications. And so there's some things happening there that I am excited to share.
Wonderful. And that's one of the questions that I think we often have. You know, we know that it's become sort of a common thought that mental health is at a crisis level in our communities. But we don't always know what it looks like, you know? And so I'm wondering, when you talk about a mental health crisis, is there a definition? Is there something that we see that helps us to define? I mean, some things are really obvious, but some things aren't until it's too late.
Sure. So I appreciate the question. And yes, I do think that COVID specifically helped to surface and created some new emerging mental health needs. The Department of Behavioral Health has historically really focused on people with severe and persistent mental disorders and substance use disorders. But we are moving really to look at a population level and look at the entire District of Columbia's population and mental health needs. And crises can look very different. There's a crisis that you might encounter on the street where somebody maybe seems out of control or aggressive or talking to themselves. But I think it's also important, again, back to COVID, the isolation, the amount of anxiety and depression that surfaced, newly emerging conditions, also means, you know, people can be in crisis very quietly. And we want to look for changes in terms of how their self-care, changes in character, mood. Most importantly, want to talk a little bit later about training that we are doing in the community and at the MPD's training academy on mental health first aid. But most importantly, we really want citizens to become more literate about behavioral health conditions and feel empowered to say something. One of the common myths about suicide, for example, is that people are afraid to mention it because they think it will make somebody more likely to entertain suicidal thoughts or to take action. And there's no evidence of that.
Oh, it's interesting because we do hear that a lot. And even for those of us in the media, how we cover suicide, you know, has been a challenge because we don't want to we're always very conscious of what the stories that we write, the impact of the stories that we write on people who may be considering taking their own lives.
Yeah. Yep. No, I've learned a lot about that recently from some work that the department is doing with the Department of Transportation around suicide prevention. But on a personal level, yes, it's important for people to be able to talk about it. And the American Foundation for Suicide Prevention even says, has a series called Talk Saves Lives. But you're right, the media, it is important for the media to follow specific guidelines and recommendations, including, most importantly, not highlighting specific explicit means and lethal means of suicide, because that has the potential for creating, raising the risk of somebody taking action.
I know that the city, we've talked about this before, where in many instances when that 911 call goes out, and you talked about this a few minutes ago, MPD shows up when it may not be an MPD issue. And
Right.
So how do you all coordinate? If that person is going to call 911, where does the crisis services aspect of this come into play, or how does it come into play?
Yep, great question. And I think, as I said, we're really working to respond as much as possible when we can safely to put behavioral health clinicians as the first responders to behavioral health crises. So a number of things are happening to make that possible. One is that I mentioned the DBH operated services. We operate the crisis call center known as Access Helpline, which is the district's sole 988 suicide and crisis lifeline affiliate. For 2 years now, we have undertaken a 911 behavioral health call diversion project that we are doing in partnership with the Office of Unified Communications, which is the 311 and 911 call center with MPD and fire and EMS. So if somebody calls 911 and there's no indication of any imminent dangerousness or a weapon or something like that, they are increasingly transferring those calls to DBH. If we can't resolve it telephonically, we have the ability to dispatch our mobile crisis team, which is part of what's known as the community response team. Mm-hmm. And they go to the person, so they take services to the person. Historically, there have been a lot of times when MPD and CRT both responded, either CRT responded and requested MPD support or vice versa. But the 911 diversion program is a new option. In addition to that, we are in the midst of standing up a co-response approach, which will pair mental health clinicians with MPD officers. They'll ride together and be able to respond when there's a behavioral health issue on a call that has come through 911 and led to MPD dispatch. So there's a whole range of options that we're trying to promote. And I mentioned just in passing 988. 988 is a 3-digit call code that went live last July nationwide. You can call 988 24 hours a day, 7 days a week. The idea is to get that to your local call center, but if the local call center somehow can't answer it, the centers are networked. So there's always somebody that's going to answer that call. I think we also, frankly, want to promote the Access Helpline number, 888-793-4357, and even a direct call to the community response team, which is 202-673-6495. But if you call 911 or 988, you end up with a DBH call taker who will work to resolve that.
So what happens, Mr. Bebout, if someone gives a call, they see someone that's having a mental health, what appears to be a mental health crisis. It's something that can't be addressed by phone. Um, the health crisis folks have to show up. And then what happens? Where's that person taken?
So I'm glad you asked. The national model, the standard for crisis care is someone to talk to, someone to respond, and a place to go. Someone to talk to is the call center, someone to respond is the mobile crisis team. And then the places to go here in the district are the community, the Comprehensive Psychiatric Emergency Program, known as CPEP by shorthand. If somebody needs to be evaluated and stabilized, they can go there for up to 24 hours, extending up to 72 hours. Obviously, we are trying to use the least restrictive means, but sometimes people are picked up for an involuntary hold for evaluation and may be admitted to an inpatient psychiatric facility. In addition to CPEP, I think Dr. Moise may have spoken about this last week. We are poised this fall to open the district's first stabilization and sobering center for people that are experiencing acute intoxication, or so that we can avoid unnecessary transports to emergency departments when the vast majority of people don't need emergency level care. The other thing about the stabilization center is that we really see it as a low barrier entry point to hopefully engage people in ongoing services, which just doesn't happen. EDs or emergency departments are simply not really equipped to do that. So people get treated and released, and often we miss an opportunity to try to engage them in care.
You know, we're running a little bit out of time here, but two questions that I have left. One, when a person experiences this mental health crisis and they're, taken to a place where they can get care, who pays for that? Is the city paying for that, or is it their own Medicaid, or what happens?
Much of what we deal with is, as you know, the district has an incredible penetration with Medicaid. So most of it is Medicaid reimbursable. In terms of the crisis care, CPEP encounters are Medicaid reimbursable. There are costs that are part of our local appropriation, but by and large, there is work to be done here and across the country for private insurers to also begin to pay their fair share for crisis response. But by and large, individuals are not bearing that cost.
So now that this crisis, service has been created, what will residents see, or should we see, that's different? Just like we have a new assistant police chief, for example, and who is really going to be tough on the crime that we're experiencing in the city. So people are going to be looking around and say, okay, is her leadership making a difference? What will we see differently with the crisis services? And I ask that because, there are communities across the city where we see things or individuals in the streets or on the streets in conditions that are abnormal. And it could be, like you said, substance abuse related or what have you. And just knowing when you need to make that call on behalf of that person, or, should we see less folks out there in distress because you all have become so busy, or will you become so busy?
Well, we are expanding so that we have more capacity for mental health response to mental health crises, behavioral health crises. I do want to add one other thing with respect to our are good partners with MPD, which is the mayor, the chief, our director have committed to all officers being trained either in mental health first aid, which is a nationally known curriculum, or in the crisis intervention officer model. So everybody's getting mental health first aid training before they finish at the academy. Every officer on the street is getting mental health first aid training or is being trained as a crisis intervention officer. Again, we're trying to get behavioral health clinicians to respond to behavioral health crises.
Mm-hmm.
We're looking at alternative transportation strategies and things like that. But police are invaluable as partners in this and do encounter people in behavioral health distress. So we want them to be better equipped and have skills for de-escalation, helping to talk people down when there are general police aspects of general police training have the risk of somebody in behavioral health crisis actually escalating.
Mm-hmm.
Police are supposed to take command of a situation, and that may not be the best way to approach somebody that's in distress.
Right. I understand that. And this would be for both adults and juveniles or children?
Yes, the city does have a mobile crisis for children and adolescents as well as for adults.
Okay.
That is all part of our umbrella. And it is a piece of the training, the mental health first aid training and crisis intervention officer training that MPD officers are receiving.
Well, Dr. Bebout, you know, we know how essential the service is in the district. We're glad that the mental health advocates found a friend in the city government and leadership there to say we've got to do things a little bit differently, and how do we address this mental health crisis that we're seeing, not just in the district, but all over. And I think you said COVID did help to exacerbate the problem. So we are really grateful that you all are here to share this information with us weekly. And we look forward to hearing more about what your office is doing to help us to become a well community.
Thanks so much for the opportunity and appreciate your support.
All righty. Have a good one.
Take care.